So now that we have finished discussing the esophagus, the stomach, the duodenum, we move on to the next structure, which is the liver, right? Now, because we say that the liver is part of the foregut, we expect its blood supply to be coming from the celiac trunk. So we are going to be having the common hepatic artery, which is coming from the celiac trunk, which is going to be giving us our gastroduodenal artery, and we are going to be forming our hepatic artery proper. That hepatic artery proper, which we then divide into the right and the left hepatic artery. So we're going to be having that right hepatic artery giving us the cystic artery to the gallbladder, and we'll be having the right hepatic artery supplying the right lobe and the left hepatic artery supplying the left lobe. Point to note is that the caudate and the quadrant lobe, they are supplied by the left hepatic arteries. Okay? So now we move on to the liver, how it forms, right? So we are going to be having our straight gut tube like this one. And around the 3rd week of development, you have got something that you call the liver diverticulum or the liver bud that is going to be forming here. So you can call it the hepatic tissue, the hepatic, the diverticulum, liver, all the same. It's going to be coming from the distal end, the distalmost end of the foregut. So it's going to be moving up and it's going to be invaginating into the tissue of the septum transversum, which you said it also responds to take partakes information of the ventral mesogastrium. Right? So we have the liver now invaginating into that septum transversum, and we'll be having the connection between that diverticulum. So we have this diverticulum. The connection between this diverticulum and the duodenum is going to be forming our what? Our bile duct, right? And then we are going to be having a branch or a bud that is coming off from this diverticulum. So from this hepatic bud, we are going to be having something that we call the cystic bud that's going to be forming from this duct, right? So this cystic bud is going to be forming the cystic duct and the gallbladder, right? And we're going to be having these cells that are going to be going into the liver, going to be dividing into all those ductal systems, whereby we divide into the right and the left hepatic ducts. They're going to be coming from this, right? And now the cells of the liver, we're going to be having those hepatic, the hepatocytes, right? The functional cells or the parenchyma of the liver. They're going to be coming from the foregut, right? Those cells, they don't come from the septum transversum, right? We're going to also be having the other cells like the Kupffer cells, we're going to be having the connective tissue stroma, all the stroma that's going to be found around the liver. It's going to be coming from the what? From the septum transversum. So you see the cells of the liver, they originate from two, but the functional cells, they don't come from the septum transversum. We only have the Kupffer cells, the connective tissue stroma that's coming from the septum transversum. But the main cells, the hepatic cells, the hepatocytes, coming from the foregut, right? We are also going to be having things that you call sinusoids, right? The liver sinusoids. So liver sinusoids, they come from our vitelline veins in the umbilical vein. If you still remember when we were doing the cardiovascular embryology, we mentioned those veins. So the umbilical vein and the vitelline veins, they are going to result in formation. The remnants are going to be forming the liver sinusoids. So now we want to discuss the ligaments of the liver, right? We are going to be having the less omentum coming from the lesser curvature of the stomach to attach to the liver, right? So the less omentum, as I mentioned before, we are dividing into two: the hepatoduodenal and the hepatogastric. Okay, hepato means liver, hepatoduodenal from the first part of the duodenum, and the hepatogastric from the lesser curvature of the stomach attaching to the liver. Still, a reminder: in the hepatoduodenal ligament is where we find our portal triad. Again, yeah, you need to remember that. Okay, but we also have another ligament that is joining the liver to the anterior abdominal wall, which we refer to as the falciform ligament. Okay, so apart from the falciform ligament, remember when we were talking about fetal circulation, we mentioned something that we called the umbilical veins, right? So the embryological veins, they are going to have a remnant that we refer to as the round ligament, or we now call it the ligamentum teres. Okay, that's going to be taking part in partitioning of the lobe, forming the quadrate and the chordate lobe, right? They're going to be taking part in that partition. Another also important point to note is that we have got an area of the liver. Since the liver is going into the septum transversum, and the septum transversum is forming the diaphragm, we have an area of the liver that is not covered by peritoneum and lies in direct contact with the diaphragm, and we refer to it as the bare area of the liver, right? Okay, so those are most of the important things that we need to remember about the liver. Also, we need to know that initially in fetal life, we have got the liver that contributes to around 10% of body weight. Because the liver, what it does is it's part of hematopoietic structures prenatally, right? So we are saying that in the embryo, the liver takes part in formation of our blood cells, right? So it's going to be 10%, but close to birth, the liver reduces to about 5% of the body weight, right? Okay, so now that we have finished discussing formation of the esophagus, the stomach, the duodenum, the liver, it is now in the gallbladder. It is now time for us to discuss formation of the pancreas, right? Okay, so like we said, if something is in the foregut, we expect it to be supplied by the what? We expect it to be supplied by the celiac trunk. But something special about this, because most of these structures that are located at the junction will get dual blood supply. You know that the pancreas is also supplied by the superior mesenteric artery, right? So we are going to be having, since the pancreas lies in the concavity of the duodenum, the artery that supplies the duodenum will also supply the pancreas. Remember when we discussed the superior pancreatic or duodenal artery from the celiac trunk and the inferior pancreatic or duodenal artery from the superior mesenteric artery, all those are going to be taking part in supplying the what? The pancreas, right? And we also have got the splenic artery. When the splenic artery is moving on the upper border of the pancreas, it's going to give around 10 branches that supply the body of the pancreas. Okay, you also need to know that. Yeah, okay, that's good. So we realize that the pancreas is supplied like that. So now that we have discussed the blood supply of the pancreas, we need to know that around the fourth week we are going to be forming two buds here or here. We're going to be forming a ventral bud and a dorsal pancreatic bud, right? So we've got two buds, ventral pancreatic bud and the dorsal pancreatic bud, right? So we are going to be having these two buds. There's going to be rotation, since they are now attached to the second part. And remember when I was talking about axial rotation of the duodenum, which you say the second part of the duodenum is going to be rotated. So when we have axial rotation, we are also going to be having the ventral pancreatic bud is going to start to move, right? To the right, it's going to rotate. So as it rotates around the second part of the duodenum, it's going to come and trying to fuse with this dorsal pancreatic bud. So this dorsal pancreatic bud, what it's going to be doing here in the dorsal mesogastrium is going to be also elongated. Okay? It's going to be elongating posteriorly. It's going to be increasing in size. Or the ventral is going to be coming so that it comes here and it's going to fuse. So when it fuses, it's actually going to be a little bit inferior to the dorsal pancreatic bud. Because it's inferior to the dorsal pancreatic bud, it's going to be forming the lower part of the head of the pancreas. It's going to be forming our uncinate process, right? Now, what we really need to know here about the pancreas, we need to know about the duct system of the pancreas, right? So we are going to be having the pancreas is going to be the ventral is going to be having its own duct that's going to be emptying into the duodenum, and we are going to also be having the dorsal. So the ventral we have got a duct, the dorsal is going to also be having a duct, and we are also going to be having the duct, the bile duct as well. So they are going to be joined, all these ducts. So you're going to have, as the ventral comes here, comes posteriorly, it's going to join together with the bile duct, and also from the dorsal pancreatic duct, the duct of the dorsal pancreatic bud is also going to be joining, and we are going to be forming our main pancreatic duct, right? Which is going to be emptying into the second part of the duodenum, and we call this the main pancreatic duct of Wesson, right? It's going to be draining into the main duodenal papilla, right? But in other situations, we can have the dorsal pancreatic bud that empties at an area that is like 1.3 centimeters above the major pancreatic bud, right? This area where it's going to be emptying into, we call it the minor duodenal papillae, and we refer to that one as the minor pancreatic bud, or the accessory pancreatic bud of Santorini, right? So those are the ductal systems of the pancreas, right? So we are going to be also having this situation around the 4th month of development, whereby the islet, we are going to be forming the islets of Langerhans, okay? The islets of Langerhans, these are cells of the liver, the beta, the alpha cells that are endocrine in function. So they are going to be forming from the pancreatic parenchyma. So from the pancreatic parenchyma, we are going to be forming what? Our islets of Langerhans. Okay. So now after all this rotation have happened, what we will see is we are going to be moving. We are going to be seeing that the ventral pancreatic bud will rotate, and the area is going to be on the inferior aspect of the dorsal pancreatic bud, right? And the buds that are going to be joining here to form what? It's going to be joining. This is the bile duct. This is the main pancreatic bud. So they have joined here to drain into the major duodenal papillae. And we say we call this the main pancreatic bud duct of Wesson, right? Then we can also have this dorsal emptying at a point above, like I mentioned, from the pancreatic bud of Santorini, right? So this is how the structure is. So we need to know that the openings, they will move from a more anterior position initially, and when we have axial rotation of the duodenum, they are going to be moving to a more posterior position, like this, right? Okay, so this is the normal development. Our question is always, what can go wrong, right? So what can go wrong in development of the pancreas? Okay, we have number one, something that we call accessory pancreatic bud, right? Accessory pancreatic bud. So an accessory pancreatic bud, we're talking about buds of the pancreas that can occur anywhere along this gut tube, from the distal end of the esophagus, okay, to the proximal end of the primary intestinal portal, somewhere down here, right? So we can have a pancreatic bud form along this whole gut tube, right? It's an accessory pancreatic bud, right? We can also have something that we call annular pancreas, right? So annular pancreas, initially, what we are expecting is that we have got our ventral pancreatic bud here. We expect it to go along the right side like this. It's going to fuse inside the side, right? But what happens in an annular pancreas, we have a portion of the ventral pancreatic bud just going to move in the normal direction, but another portion is going to oppose and move towards the left. So we are going, instead of this, imagine that there's a duodenum in front, we're going to be having one moving in the right direction, one in the other direction, such that they're going to encircle the duodenum, right? When they encircle the duodenum, we will also see similar conditions to the one that we were discussing about the pyloric stenosis. But what we say is, after injection of food, there is that vomiting or that injection of food. But here now, because this is around the region of the bile duct entrance, we will see that the food that's going to be ejected contains bile, right? So this can help us to distinguish between an annular pancreas and something like duodenal stenosis that's happening up there, or something like pyloric stenosis. Okay, so right now this is the end of our foreguards development.